so forth. If you take a look at what happened between 2019, maybe January to May 2019 and January to May 2020, let's look, say, for instance, routine immunization sessions dropped by almost about 10% from 95 to about 85. And fewer children across board are getting services that they required in MNCH. But specifically for antenatal care and reproductive health care, there's no doubt that we have had a lot of downturns in the attendance. The antenatal care, the part of the SRH, for instance, shows that we have a decrease of almost about 100,000 in 5 months in 2020 compared to similar period between January and May 2020. These are what have become worrisome. So to do justice to these policy gaps and what is happening to essential reproductive health continuity post-COVID or intra and post-COVID in Nigeria, we have a team of specialists, many of them rolled into one. And our colleague, Dr. Oluwatosin Kolade, is an associate director of health financing with Health Systems Consult Limited. He will speak on what his perspective will be on how the sexual reproductive health, how integral or how it has really co-moved with COVID-19. But specifically, we would also want him to help us to address how he thinks that the insurance mechanism is integrating with sexual reproductive health in COVID-19 era. So you're welcome, Dr. Kolade.
Thank you very much. Good afternoon, everybody. It's a good honor to be here, and congratulations for all those who survived both the COVID pandemic. It's been a global health security challenge. Having said so, the public health as one of the major sectors, aside other sectors around economy, education, and the like, is a majorly affected part of the entire spectrum. This has actually caused for major concerns, and it actually exposed the level of the fragility of a lot of health systems globally. Africa and Nigeria in particular are no exceptions. If for anything at all, this actually showed the extent of, so to speak, some policy gaps that should have preceded preparations, proactive preparations to address health emergencies, public health emergencies of this nature. Understanding that a few years ago, 2015 thereabout, we were just hit with the Ebola, and so that should have been the wake-up call. However, 2020 has now been, so to speak, the wake-up call. And we've seen indices actually go on the negative in terms of what has been achievements before now being reversed. And one of the key areas that it's really been affected is the gateways for our health system, which is the public health centers. We found out during the COVID that this was one of the most hit level of care. There were a lot of across for SRH services, including family planning, just like Dr. Anamba did mention about. We saw a dip in access for an uptake for services like routine immunizations, antenatal services, family planning services, and these are, of course, major concerns, which would actually require more than ever before some policy reviews or reforms to actually help address this in preparation for any of such public health emergencies to come. Interestingly, prior to COVID, there had been some very good mileage achieved, both at the national and the subnational level, where we had health reforms around that were centered around the primary health care. So we're doing some sort of entire system strengthening, where we had reforms around the PHC under one roof reforms. We have reforms around the basic healthcare provision funds, which was a federal, national intervention, so to speak, like a buffer for the states. And of course, the 2015 Act that actually gave birth to the decentralization of insurance into the states. These are reforms that, to a large extent, even pre-COVID, would have actually helped. Some of the things that were very critical to some of the poor outcomes that the COVID gave birth to were around cost of healthcare. There was the issue around availability of access. Then there was issue around even the cost. COVID brought about a situation where, like in Nigeria, where there was a lockdown for about 6 months, the earning powers of citizens were reduced, knowing very well that over a good percentage, over 60% of Nigerian population is in the informal sector, and a good number of them are daily earners. The purchasing power for health was actually reduced, and so we had more of this actually affecting our on the long run would affect our health indices. There have been some discussions around the mortalities recorded during the COVID. How much of them were directly COVID related? Because we had so many of indirect fatalities, which were as a result of some of these factors that I actually mentioned. And a policy review would have helped some of these situations. A major policy review discussion that is now ongoing is a review of the National Health Act, which speaks to the need for the first being making some financial mechanisms being mandatory. The National Health Insurance Scheme has been on for over a decade and still remains non-mandatory. That on its own is a major policy gap that needs to be addressed. But interestingly, the decentralization of the insurance from the national to the subnational from 2015 has actually given a lot of the states to come up with their state social health insurance schemes. And different states as at today are at different stages of their setup. But at the last count, we have well over 16 states who have done the needful around the setup of the state insurance agency as their scheme. Also, you cannot have a complete insurance package that looks only at the demand side. So also the setup of the state primary healthcare development agencies has also helped in who serve as the subnational regulators for the PHCs, which are the entry point for health. These are very key conversations that need policy conversations that actually needs to continue. There's a need to actually strengthen that primary healthcare level such that the health systems are as robust, are strong enough to be able to provide the expected services around the expected basic primary healthcare services around the SRH and the family planning. There is also that need to look beyond just seeing the primary healthcare services available at only the public facilities. The need to expand the providers to the level of the primary care to the private facilities is also very essential. Studies have shown that over 60% of access and uptake of healthcare is actually done at the private facilities. So the need to actually integrate them into the provision for health services is very key. Interestingly, the National Health Scheme has actually always ensured that there is both the public and private facilities on its scheme. But beyond that, we need to take the next step into the community pharmacies and the PPMVs, where uptakes of services are also very, particularly for SRH and FPs, are also very high. And so there is that need. So, this actually has given us some very good insight into where our policy gaps have been and where we need to actually channel some of the energies into improving on our indices as it speaks to post-COVID. And these are some of the lessons we've actually taken from this. Thank you.
Thank you so much, Dr. Kolade. We know that you touch on several issues, particularly looking at some of the results of the lockdown that took place, issue in terms of service delivery gaps, particularly as it relates to SRH, family planning, the issue around antenatal. You bring to the forefront some of the issues around how even immunization rates were affected. It was already low prior to the COVID pandemic. And some of the gains that we were able to achieve have retracted. But one of the things that we want to hear more from you, what SRH policy gaps did COVID expose in your intervention as regards to SRH during the post-lockdown? Yeah, just in terms of your experience, what you've seen happening across Nigeria, outside of what you've shared during your intervention. Is there any other thing that you think as in terms of the government, in terms of healthcare systems across Nigeria that we have to really take into consideration? Even thinking in the context of when we have available vaccine, what are some of the things that you think we need to address post
Okay. So thank you very much. So it's suffice to say that what are the other things we need to look at beyond the policies, what these policies can speak to, and beyond what the policies would actually help speak to, and it's all to achieve one goal: ensure that there's access, and then there's beyond the access, there's a demand generated for it, and as well as there's uptake for it. Okay. And like I mentioned earlier, aside those other reforms, the health reforms that actually come up, there is that need, and which, like the states have already started addressing, but there's a need now to make it some form of a national. The approach might be some level of a top-bottom approach, because we have countries we can actually learn from, which I think in the course of this panel discussion, I might want to throw some light to, so that we take learnings from some countries that have actually achieved where we in getting to where we are desirous of getting to, particularly around our SRH and family planning. There's a need to look at what is in our drive towards actualizing universal health coverage. How do we want to ensure that both at national and the subnational level, universal health coverage is seen as that journey that must be holistically achieved? Holistically achieved in the sense of across the availability and the delivery, and as well as the uptake, because where these services are available and they are not being taken up, there's an issue. A very key component of all of this is the supply chain aspect. Yeah. So reforms around the supply chain, it's very critical in us in actualizing this. But interestingly, I think the startup point would actually be looking at the win from the governance side. And this actually speaks to understanding the need for policy revisions, new policy designs, also the need for stakeholder understanding and advocacy, continuous advocacy to get their buy-in. Of course, in all of this, there will also be that need to understand that for every addition to currently, majority of these services are being provided from the donor side as a vertical program. Mm-hmm. there's that need to begin to think integration. How do we actually now have these services integrated into the designed financial sustainable financing mechanism, which is the insurance we're using towards actualizing universal health coverage? How do we want to mainstream the SRH services, the FP services into the insurance? Like I mentioned earlier, the supply chain part of it is also very, very important. And of course, the third aspect of it is the governance level, to be able to have the necessary buy-in across stakeholders from the political and the non-political part, as well as beneficiaries and the side of the providers.
Thank you so much.
Thank you, Dr. Kolade. Well, we are privileged to have in our team here. We cannot hide it. His Royal Highness Dr. Halilu Yahaya, the Emir of Shonga, the frontline medical practitioner in Nigeria, one of the big bosses in the health sector. So it's not asking questions, but we are happy that he's here. And though he's not originally part of this program, but we cannot allow such an opportunity to elude us. So Your Highness, I know you don't know what to talk, but you will please kindly permit me. You're my former boss, and you have always been my boss. What do you think? What's your perspective of continuity of essential services in this COVID period in the community, for instance? Yeah. Essential services. What's your insight into how it's moving? How can we improve it? Because we are not going to get back to the normal again. Sorry, sir. Just your insight.
Well, I think, thank you for forcing me to contribute at this time. But I have listened to all your previous contributions, and you've covered considerable list of grounds. I don't think you've left any real gap. But the important thing is, whether we like it or not, we're overwhelmed. And I've always said 100% of small is still small. If our resources are dwindled, then our services that we can offer can only be that much. So there's a need for real sitting down, replanning and re-strategizing and prioritizing. Now, the services like this one and the increased gender-based violence and so on and so forth are things we must give priority attention to, because they only get worse and it can compound what's going to do. There's going to be increased attention to real preventive promotive health. Absolutely essential. So just overhaul the system. And then now we're also having humanitarian. We're looking at so many, we're firing all cylinders, yet we have little resources. And so it requires dedication, issue of appealing to the healthcare team that what they're doing is more than just offering service, but actually trying to bring their faith, their religion, their humanity into what's going on. And I think that is just a contribution I have to make, but it's a time for real national sacrifice. And donors don't come anymore, so don't expect anything. And we've got to rely more on our resources. And so I think, like I've always told people, it's time for us to now sit down and really re-engineer the country, or reorientation of the youth over next few years, should begin to give us kind of dividends we need. Right now, we've got to keep telling ourselves the truth. The issue of continuous, persistent, strategic communication becomes very, very important here. Sit down and say, what do we do, and repeat in what manner to get people to really begin to see where the truth and contribute their own resources towards making things happen. Okay, the insurance, for example, people talk about the insurance. The amount they're giving the Basic Health Provision Fund and all, is still quite small. So we still have to bring in our resources. Very unfortunate, because we're kind of out-of-pocket expenses, but we still have to go back a little bit. So that's just all I'm going to say. But I think I've listened very hard to all you can say, and I think you're really spot on. Thank you very much.
Thank you very much, Your Highness. I can see your passion, because you are one of the pillars that actually drew and conceptualized, and during your tenure as the chairman of Health Reform Foundation of Nigeria for the National Health Act. And I also see how you normally passionately discuss, and there's a phrase that you have mentioned twice here, which is quite like you, that 100% of small is still small. Thank you very much, sir, for your insight. Just one question for me to you before I hand over to my co-chair. And this question is I hope I'm fair about that. What specific pragmatic domain in the basic healthcare provision fund do you think needs to be tweaked to address essential services during health emergency, not pandemic now, because we may not have another pandemic until the next 75 years. Maybe but we keep having endemicity and keep having emergency all over the whole place. I'm saying this in view of the fact that the basic healthcare provision fund, of course, there are provisions for demand side, and you are in the service insurance, something that may also provide one of the sides. So if you have to just make a suggestion on what do you think can be tweaked in the basic healthcare provision fund, the newly amended and the newly revised basic health provision fund, how do you think we can move that one forward to take care of issues of essential services during health emergencies?
Okay. It's quite daunting question. The reason being that you just want me to just speak to one, but I would actually say that I would want to believe we know that they are just beyond one on this side. We could pick one from the demand side and could also pick one from the supply side. Speaking to specifically one that would have actually helped in terms of health emergencies, public health emergencies, would have a thematic area I think I would look at in the entire spectrum of the basic healthcare provision fund would be the aspect of the health benefit package. The current health benefit package speaks to a minimum service package. However, what is the extent of the completeness of that basic minimum package for health? I'll give an example. At the moment, what is being covered, if I stand to be corrected, like for a service under family planning, it speaks more around accessing care from providers who actually provide such services. And if we look at that, that will not actually help us move us from where we had to the target areas, in terms of our MCPR. What we have at the moment is something around counseling, and at the highest, some accessing some consumables, not even the commodities. So there's a need to actually look into that health benefit package aspect and make it have some completeness, so that you can have the full complement of the family, of the FP service and even the SRA services to be provided. There is a roadmap to actually how to achieve this. So it's not something that you want, and of course, in doing this, you definitely need to touch on the aspects of the supply chain, as mentioned earlier, which now speaks to the provider aspect of it. For these provider aspects, I'm sorry, I have to go beyond one. You need to look into the availability of services. You need to look into the HRH, the human resource for health. What's the level of availability? Before the commencement of the BATE CPF, before it was finally signed off, there were assessments of what we had in states, so to speak, pilot states then. But interestingly, it showed more of our areas of gap. There'll be a need to actually look into the entirety of the provider aspect, the supply side of the service provision, because it is one thing to say to generate demand. It's another thing to get to the facility and actually be able to access what they've been promised to take up at the facility. And one of the major issues that social schemes like the insurance that is being brought up with the BATE CPF is tailored around, or desired around, is the issue of the beneficiary trust. And this trust thing comes in when whether I've paid for or I've been paid for, there's some form of purchase for services, and I get to the facility where I'm supposed to access the care and it's not available. This is where the trust begins, the public trust begins to dwindle and begins to actually affect the uptake of insurance. Like I said earlier, for countries where they've actually seen what are the mechanisms to actually use in sustainably mainstreaming SRH services and FPs, which insurance has actually worked, you find out that there was the end-to-end of the design of it. And insurance actually shows to be the game changer in actually improving the MCPR for a family planning. And those are the things I think we can actually build on to actually help improve how much of the essential services are available and how much the uptakes are, and it can be on a sustainable strength.
I'm sorry, I just have to nip this one in. You talk about human resources for health, but I recall that close about 2-3 years ago, we were also discussing the issue of task shifting and task sharing. And the main domains were actually on the reproductive health, family planning, and to a very large extent on the pharmaceutical services. So what do you say about that? Where are we?
It's a long journey. Where are we? The good thing is, like I said, proactively, the federal government had actually started some preventive mechanisms and in terms of the reforms, and that's what brought about, in realistically speaking, in our climate, what are those reforms that could actually help us address the issues around the major gap we have in the human resource for health. And that's where the issues around the tax shifting and tax sharing policies, they come in place. And to a very large extent, it has helped. It has helped in terms of the human resource, but in terms of commodities, there's still been that gap. Availability of commodities at the facilities is still a major gap. And this has actually, so you still have issues around stockouts, beneficiaries actually accessing care to the extent of maybe even laboratory services, but not the final uptake, which most times are the pharmaceutical services. This is still a major gap that the TSTS policy that was brought up still needs to address. And like I did mention earlier, in the entire scheme of things, the supply chain is very critical in ensuring that provision of services is key to addressing availability of essential services. Part of what happened during COVID was the entire supply chain system was disrupted. So people, even when they could risk and get to the facilities, the commodities were not available. How do we begin to look into reforms that actually makes provision for this preventively, a proactive way in addressing all of this? So in the scheme of things, it's very critical in ensuring that the entire solution provision is look at it from that helicopter view, so that you have the end-to-end solution and not just some silos of solutions, such that you still have those areas of gap. But ever than before, this COVID has actually now have taught us that there's a need for us to plan in advance rather than to be very reactive in a whole lot of provision of essential services. Thank you very much.
Thank you, Dr. Kolade, for your sharing and the information. You really brought to our thinking a lot of the things that we've heard been passing around in terms of the issues around what the pandemic has caused in terms of disruption in services, as you correctly mentioned, disruption in supply chain, issue around the insurance and some of the gaps that still exist in that regard, even though we've seen some key advancement at the state level, which is very laudable. But I also want to emphasize what our Emir shared, the need for more preventive and promotive healthcare system. And I think that is one of the things that we also have to re-examine as we move forward to strengthen our healthcare system, to try to ensure that we try to reduce accessing treatment and people can now adapt more a healthy lifestyle of ensuring that they take care of themselves. But we really want to try to ensure that coming out of this session, as we move forward, some of the things that you shared that we will table within different forums so that we can see how we can address some of these key policy gaps that exist My co-chair, he rightly brings to the forefront some issues around the basic healthcare and provision fund, and you have also added to that to say what are some of the gaps that exist within that. I want to just bring us back just quickly before we close to the supply chain aspect that you brought to the forefront. And it was not only looking at the availability of commodities, but other essential medicines that were so much needed during the lockdown. And for us, in terms of our role as health development partners, it is for us to try to ensure that we continue the conversation, but also put things into action so that we can actually address some of the policy gaps that exist so that we do not have this challenge moving forward. And as Dr. Abanin had said, it's not just about the pandemic, but just simply small health emergencies that we want to ensure that the healthcare system can respond to appropriately. So I want to thank you so much for being here with us this afternoon. You've really shared some very key elements of health issues around the COVID-19 that have been kind of, like I said, bring it more to the forefront and for us to try to see how best we can move forward as a country to address. Emir want to say something? Okay, so our Emir would like to.
Yeah, His Royal Highness would like to say something. I think it's by providence that he's here at this particular meeting, because for most of us, we know that the first pilot case or pilot testing for community health insurance in Nigeria is his emirate. And there's still a lot of papers have been written to wants to say something. Thank you, sir.
Now, actually, I don't think I'm contributing much except defining the boundaries and defining how our mindset would move. Certainly, we've been exposed, and people who didn't think health was important before have suddenly realized that actually health is all of it. And not having gotten health right, then everything, education, everything stopped, economy stopped. And so for the first time, people understand what health is wealth means and how central health is. So people can sit down and say, I want to just give priority to education. Keep doing so. But health comes and destroys everything. Child cannot go to school. And so if there's nothing COVID has done, it has now brought health to the top of the agenda. And people are prepared to divert resources, even for a while, towards getting that point right or giving modicum of service. So you see prioritization that leads to stopping a few economic activities here and there, a few investments here and there, once again, because it has a multiplier effect. I think this is one thing I like to just use to cap the direction things should be going. And so yet there'll still never be enough resources, but at least there'll be better resourcefulness than before. Thank you very much.
Thank you, Your Highness. Thank you. Is that something? All right. Huh?
Okay. Okay, so just to ride on what the Royal I just mentioned. I was one privileged to be in a conversation room where there was that discussion around which was most essential: health, education, and some other sectors. And but during the COVID, I actually had to speak with who was like the moderator of that session, and I asked that question: do we have evidence-based now on which of those sectors was actually most important? Because it wasn't a thing of I think it wasn't rocket science. It's actually there. This is something that actually is cross-cutting. It didn't actually pick out one sector to say, oh, I'll just affect only the sector or such certain group of individuals. It was cross-cutting. And so this has actually told us that there's no one country in the world that has all the health immunities, but however, there's a need to begin to review reforms and introduce reforms that are people-centered, that are sustainable, have community-based, that entry point, that has the promotive and preventive as elements of the reforms to be introduced. As much as possible, every stakeholder is essential to be sensitized continually in ensuring that for us to achieve our dream actualizing all of this, we all need to bury all our titles, all logos, all whatever it is, our paraphernalia, and know that essential health for one is essential health for all. Thank you very much.
Thank you very much, Dr. Kolade, for beautiful intervention and for your participating in this program this afternoon. Your Royal Highness, we want to thank you very much for your intervention and for the very fatherly contribution. It's also very highly technical. We learned from that. To the technical crew, we want to thank you very much, and the organizers of the FFFP 6FP conference want to thank for the opportunity. My co-chair, Erika, and myself were pleased that this session will be drawn to a close now, and so good afternoon all.